Hi everyone, my name is Julia Thorpe, and this is my NU661 primary care childbearing women presentation at Regis College about methamphetamines or meth during pregnancy. So, starting with a general overview, meth in America. Over the past decade, meth has become exponentially more common and widespread. Between 2009 and 2019, there was a 53% increase in the number of women using methamphetamines during pregnancy. Between 2015 and 2019, overdose deaths from meth more than doubled, and arrests for meth possession rose by nearly 60%. In 2019, over 2 million US adults reported meth use, and more than half met criteria for a substance use disorder. Fewer than one-third of people with meth use disorders received any type of treatment, despite high rates of co-occurring mental illness that usually happens. So, because I live in Arizona, I specifically researched meth in Arizona because it is a very um, commonly used drug here in this state. So Arizona is actually notable for having three cities ranked among the nation's top 10 for highest methamphetamine use. Phoenix, Mesa, and Tucson are all on the top 10 list, if that gives you any insight as to how common it is in this state. The overdose rate for meth in Arizona in 2023 was 12.1 per 100,000 people. And meth continues to be a significant issue in the state of Arizona as it is relatively cheap. There are also many meth labs in America, and specifically, if you look at this map, most of them are located in these highlighted states where meth is the most common. And this makes it easy for access and distribution. Additionally, established trafficking routes help with easy access. So, meth specifically during pregnancy in Arizona, between 2016 and 2018, when um, looking at 94 pregnancy-related deaths, 54.8% of those mothers had used methamphetamines during pregnancy. In a postpartum women's survey, meth was the most commonly used drug by pregnant women in Arizona. 53% of those who admitted to having a substance use disorder stated that they had used meth. And then when looking at women using meth during pregnancy, it's been found that they tend to be less educated. They either have no insurance at all, or they usually have public health insurance. And they tend to receive limited prenatal care and counseling, whether that be because they don't know that they have access to it, they um, aren't willing to go to the doctor's appointments, whatever the case may be, they tend to get less care for both themselves and their baby. And then these women tend to have pre-existing comorbidities, whether it be physical health issues or mental health issues. So maternal risks when mothers use meth during pregnancy, hypertension disorders such as gestational hypertension or preeclampsia are very common, and then as well as other cardiovascular problems. They also can experience a placental abruption. They tend to have severe maternal morbidity rates, and because meth is metabolized by the liver, depending on how much the patient has used, they can also experience hepatotoxicity. And then perinatal risks for um, when using meth during pregnancy, this can put the fetus at great risk. It can cause things such as preterm labor or preterm birth. There tends to be poor fetal growth. There also tends to be a lack of prenatal care, which I mentioned earlier. And then additionally, meth crosses the placenta and it's also found in breast milk. Therefore, the fetus and newborn baby are directly exposed to this. And if the mom decides that she wants to breastfeed, it's probably advised that she does not. And then fetal risks. While the fetus is growing, they are put at risk for many issues if the mother uses meth at any time during the pregnancy. The baby will most likely be admitted to the NICU, whether it is for being born early, small birth weight, whatever it is, they do tend to be admitted to the NICU. And then infant death is more common for babies who are exposed to meth in the womb. Also, neonatal hypoglycemia tends to be more common in these babies. And finally, there are many neurodevelopmental concerns. It has been found that it causes impaired ventral midbrain dopaminergic neurons, or VMDN, which controls like the cognition, coordination, movement, and behavior. This is associated with poor intellectual functioning. Children may experience difficulties with memory and language development, and many of these children will experience cognitive impairments throughout their both their childhood and sometimes in throughout their whole life. Here is a picture I just found to kind of give you a better understanding of the many problems a baby born from a mother who uses meth could experience. These problems occur while it's developing, and then they'll experience these, like I said in the earlier slide, when they're first born, and as they grow. And so you can see that it affects not only the brain, but other organs, the cardiovascular system, the liver, even the GI system. And so screening tools for testing mothers who may be positive for meth, just like many other drugs, these are the pretty standard tests. So you have the hair test, which can detect use up to 90 days prior. Then there's the urine test, which is the most common. It can test positive 3 to 5 days after last use. Urine is optimal for a more extended detection. So if you're trying to see within the past week or so. And then blood tests, they can detect for around 72 hours following use. This is usually used to test for acute intoxication if you want to see if when they came in, if they're positive right now for meth. And then saliva test, usually same as blood, detectable for less than 72 hours following use. This is used mainly because it's less likely to be tampered with, like for example, urine, that's always a concern, and it tests for recent use. The choice of specimens should be guided really by the clinical context, and you want to kind of base it on the window that you're looking at for the sensitivity. Those are things to consider. So, subjective presentation of the patient. Patients who are using meth, they may experience a feeling of euphoria, increased levels of energy, heightened alertness, decreased need for sleep, increased sexual drive, and find themselves excessively talking. Also, positive psychotic symptoms like suspiciousness, unusual thought content, hallucinations, or just bizarre behavior. Affective symptoms could be like depression, suicidal ideations, guilt, hostility, or just self-neglect. And then psychomotor symptoms can include tension, excitement, distractibility, or motor hyperactivity because meth is a stimulant. So you would think that most of the things that they're experiencing, everything is heightened. So with withdrawal symptoms, they're most commonly described as dysphoria, fatigue, insomnia, or hypersomnia, and then having very vivid dreams and increased appetite, and then also psychomotor depression or enhancement. And then objective presentation of the patient. So patients who come in who are on meth, they usually could be found to be tachycardic, have hypertension, or are hyperthermic. They are sweating, have tightened jaw muscles, teeth grinding. They tend to have poor nutrition because their appetite is suppressed, poor dental health, motor hyperactivity and agitation, and then cardiovascular complications like arrhythmias, chest pain, MIs, or even a possible stroke. And then neurological findings would be like psychosis, delirium, or any other type of cognitive impairment. And then if doing tests on the patient, you might find elevated inflammatory markers or abnormal EKG results like tachyarrhythmia or prolonged QTCs. So, possible differential diagnoses. The use of meth can cause many problems, as discussed in the previous slides. Some issues that a patient may have, but could present as someone on meth is psychosis, whether it be schizophrenia, schizoaffective disorder, or an acute manic episode. They may not be on drugs, but the way that they're acting could make you think that they were on drugs. And then or they could be on a different drug, like cocaine, bath salts, or PCP, all these other stimulant drugs. They present sometimes in similar ways. And then it could also be someone who is having an extreme anxiety attack. They can exhibit some of the same symptoms. It is essential to obtain a detailed medical history from the patient, get information about any prior episodes they might have experienced, and then testing for drugs can also help determine the root of the patient's behavior. So, prenatal care and monitoring, statistically speaking, women who use meth before, during, and or after pregnancy tend to seek prenatal care less often and less frequently. It's essential to ensure these women get prenatal care as the mom and the baby are at higher risk for complications. So you want to really I don't know if it's more of a community outreach type of thing, but really make sure that these women know that they can get access to prenatal care because it can help save them and help with the health of the mom and the baby. And so they really should be encouraged to attend all visits, all routine visits. And they should be closely monitored for maternal and fetal complications that were discussed earlier in the presentation. And then you want to ensure you provide a non-judgmental environment. You want to provide patients with referrals for rehab and detox centers, especially earlier on in the pregnancy, if they can handle this earlier on. Obviously, the less meth the baby is exposed to, the better. And prenatal care for women using meth should focus on non-judgmental screening and addressing social factors that can affect their health and health of the baby. So it tends to be pregnancy is a time when women are more motivated to make a change because they do know that they're carrying this baby. So they are typically they have better access during this time, they have better support during this time, and it makes it a good time to um, engage them in care and treatment regarding the pregnancy and their meth use. Thank you for listening to my presentation, and here are my references that I used.